Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Professor Hitendra Patel, who is a global key opinion leader in robotic assisted surgery, telesurgery, and editor-in-chief of the World's Journal of Clinical Oncology. We hope you enjoy the GRASP podcast.
Welcome to the Global Robotic Assisted Surgery Podcast. This is Professor Hitendra Patel, and I'm happy to invite all the viewers today to listen to our global expert, Dr. Mark Soliman, who's a robotic expert in colorectal surgery and more. Welcome, Mark.
Thank you so much, Hitendra, for having me.
Oh, it's our pleasure. So, Mark, at the beginning of our podcast, we just a lot of the people who watch, they love to know how you got to the top. And so could you just tell us just a short précis of your journey to get to where you've got to right now?
Yeah, I don't know about being at the top, but I do appreciate the the compliment. No, so I have always had an interest in technology, computers, and of course, interest in working with my hands and in surgery. So after I graduated my general surgery residency in the US, I was immediately kind of enamored by this thing called a robot. And I ended up doing my fellowship in colorectal surgery and stayed on as faculty with the program that I trained in. And I felt like this device, this robot, was actually going to be the future of surgery. And I just was really more enamored of the tech and also preserving my own back and my own knees. And what I found was that during that process of me transitioning from laparoscopy and hand-assisted open surgery over to robotics, it was completely chaotic, completely haphazard, and without any guidance whatsoever. And being the person that I am, as I was going through this process, I began to kind of mentally think, how could I make someone else's learning curve a little bit easier? And at the time, I was actually also the associate program director, and then I became the program director for our minimally invasive surgical fellowship in Orlando here. And I began to get a lot more involved in nationally teaching how to do robotic surgery in terms of going to different courses and whatnot. And I think that was really prompted by me starting to publicly share what not to do, and publicly share what I learned should be done by way of YouTube, by way of Facebook, and by way of Twitter, now called X. And so that's kind of the progress that I took to basically share my best learnings and share my worst learnings as well along the path.
Which is why you're on the podcast, because I noticed that surgeons find it very difficult to talk about when things go wrong or not quite as it should do. So let's call it near misses. And you can actually learn a lot from that. So I noticed that you wrote about this in one of the SAGE's manuals about colorectal surgery. Do you want to tell us a little about that? Because it's relevant to the national picture that you've helped to develop.
Yeah, that's thank you for bringing that up. You know, I think that we have the tendency in surgery to want to always look perfect, to always look like we're refined, to always want to come off as if we figured out we have zero complications. And especially as it pertains to innovation and pushing the envelope, we're very often reserved about, number one, admitting when we failed, and more importantly, allowing other people to coach us up and to learn. And so a lot of the work that we've done has not only been about moving ourselves into the next field or the next kind of chapter of minimally invasive surgery, but also how do we, from a didactic perspective, how do we then translate that to the next? And part of it is how do we segment the operations into digestible steps, which is what we discussed in the SAGE's manual. How do you take each step of an operation and talk about the sub-steps that if one approach if one approach doesn't work, what approach could you then go and to allow that to work? So for example, doing an IMA pedicle takedown for a low anterior resection, this is the approach, but if that approach fails and you can't find the ureter, do the same thing, but go from this direction or from that direction, go lateral, go medial, go superior, go inferior. So talking through those nuances are critically important, which contributes to a lot of the work and the brain trust that we have.
Interesting. You mentioned looking for anatomy as one of the things. So, yeah, all the specific structures which you don't want to damage. So, have you been on any things where you train people in pelvic surgery with the urologist, for example? Have you done anything like that?
To the extent that, yes, so what I've done in my new life, as you will, with in this job at AdventHealth, and I'm the chief of the system now, so I have a big kind of responsibility across the state of Florida. What we do now is we actually put regular training courses on. And some of the training courses are going to be, they're multidisciplinary. So I have multidisciplinary pelvic floor surgical conferences and multidisciplinary pelvic floor surgical courses that we'll put on.
Yeah.
Similarly, we'll do the same thing for lateral pelvic lymph node dissection. And we will have some of those with urology or with urogynecology or with HPB surgeons or transplant surgeons. We'll do a lot of these courses that have some crossover, but certainly help us learn. What we find is probably the most important thing is, of course, using the patient as an anatomy guide, seeing what beautiful anatomy looks like and what weird anatomy looks like. And what we also do is, we were talking earlier about Surgeon, this app that I've had the blessing to kind of be a part of and develop. Is we have this open model where we have urologists conversing with thoracic surgeons, conversing with bariatric surgeons. We're kind of in this open environment, and we're sharing best practices across specialty, which did not, what you would not otherwise think that I could learn something from a bariatric surgeon, but I can learn a lot from a bariatric surgeon or urologist in the example that you gave.
Yeah, absolutely. And yeah, you're doing a fine job with that as well, that work. So when you've obviously been on your journey, and we are staying in the present, but sometimes it's nice to know about some of the doyens of your specialty. And anybody really, who's somebody you looked up to and thought, right, I like what this person's doing in the world of colorectal surgery. Is there anybody in mind, or I like to say any names in case you upset somebody else?
Certainly. I mean, I think that we are all built upon those that kind of brought us in the world of surgery. So there's numerous people, those that have published manuscripts that are standing on podiums. I mean, there's numerous people that you look at and you want to just be like them or be a portion of them or take this little bit of the mentorship or the sponsorship that they've given you and take it to the next level, and constantly iterating upon what other people have done. So plenty of people on social media where we understand and learn how they edit video or how they speak on a podium or how they edit a manuscript or how they lead a division. So, I mean, I think that if I were to mention one person, it would not do justice to the 99 others that have actually put me on the path of success, I feel.
Okay. You've dodged that bullet. I agree. There's so many teachers. I was going to say you must learn from your residents who come in as well, right? Because if they've been to other places, so you can pretty much learn from anyone, right? Do you agree?
Absolutely. With that? Yeah, absolutely.
Yeah.
I found that the two biggest teachers for me are definitely my trainees that come in. We have 6 fellows per year, and of course my colleagues that I surround myself with. And whether I'm surrounded by my colleagues in a physical environment like the hospital that I'm in right now, or if it's a social environment that we're constantly conversing. So for the first group, the fellows that come in, exactly to your point, Hitendra, that when they do come in, they have disparate and very heterogeneous experiences throughout all the entire United States or even abroad. They bring a special spin, a special flavor on a specific technique or an approach or verbiage that they use when they discuss certain diagnoses with patients. So the fellows and the residents that we work with are absolutely a wealth of knowledge. And I share this all the time. Like some of the fellows, I had one fellow last year who I credit with refining the way in which I suture robotically. The way she came in and the way she did one thing that she picked up from her hernia surgeon in her residency, I've adopted now and made it my own. And similar aspect is when I look at videos and watch them on Facebook, on YouTube, or Surgeon, whatever it is. I mean, you see many people sharing their best and worst practices. And that's a massive thing that we can learn from how to improve.
Yeah. So tell me, thanks, Mike. That's very honest and helpful to the people listening. So just tell me, when you are thinking about the next major complex surgery you do, which is probably tomorrow morning or today, what would you do? What advice would you give to people about how you pre-plan that pelvic operation? Let's call it pelvic, just for argument's sake.
Yeah, that's a good one. So yesterday I had two of these, in fact. So my major days are yesterday, and had a contingent of surgeons that flew in to watch me do the case, watch me do the robotic operation. First one was a horribly complex advanced mid-rectal cancer that had progressed on TNT, or total neoadjuvant therapy. So what we do know nowadays is that the biology of cancers are just, we end up operating on the worst of the worst biologies. So sure enough, I mean, so this case that we did yesterday was locally invasive into the presacral venous plexus. There was a lot of work that we had to do to get this done robotically. So in the planning process, it's all about review of imaging. I do a lot of kind of conceptual 3D modeling in my own head of how I'm going to get around this, making sure that if that's the point at which, right at that sacral curvature, if that's where it's going to be stuck, I'm going to conceptually kind of go lateral, I'm going to go distal, go lateral again, so I can target it right at the midpoint, so I know exactly how to manage that. So a lot of it's 3D conceptualization, 3D remodeling, if you will, in my own head, by using the adjuncts of imaging, and that's incredibly helpful. That plus, of course, correlating it to the endoscopic imaging that I know, and to the radiographic imaging and the progression that occurred for that patient. So that's the prep work that I oftentimes do, in addition to watching how other surgeons navigated a similar problem, and opening up to the larger brain trust that is surgery. So asking people advice, how would you do this, or how would you manage that, and so on.
Can I ask you, if you're teaching your residents and you 3D conceptualize in your brain, how do you get that information across to the resident? I'll bet this is not a training operation you're doing, obviously, but you're still describing things to the people watching. So how would you get that across, that 3D model in your head?
Yeah, it's the adjuncts that I use for exactly that point. Now, again, we don't have the capabilities like on the ready to just 3D reconstruct an MRI, for example.
Yeah.
But a lot of it's just, we do a pre-op huddle in which we'll sit there, we're going to review images, or in our MDT, we're going to talk about things. And oftentimes we'll say, okay, I think what we're end up doing is, I know I'm going to show you in 2D, but I'm going to target it from the inferior edge first. We're going to track our way back up. So really just kind of doing a pre-operative huddle. And oftentimes, because the beauty of robotics, we'll just both sit back because we have dual console. We'll stop, we'll come back, and using my hands and fists and a series of pens and markers, just I think this is what we're going to end up doing next. And so a lot of it's just conversation and looking at my fellows as colleagues, because they're if they weren't with me for the year, they would be next door as a faculty member.
Yeah. You're far too nice a guy, Mark, to use your fists, I'm sure. I don't believe that, but so let's move on a little bit. Obviously, you do lots of teaching, lots of demonstrating. What sort of training or what sort of things do you do to continually keep your skills up, to allow you to be the great communicator you are, and the great sort of visionary that you are? What do you use to help you stay on track and stay at that level?
Well, I appreciate the compliment. I think there's two major buckets there. The first bucket, in terms of the technical refinement, is 100% video review. Until today, I've done close to 1,000 robotic colorectal operations, and I've watched every single one of those videos. Now, not in single speed. I'll sometimes watch them in 30 times speed. But the point is, I'm constantly looking at what I did in that one operation, reflecting on the performance that I did in that operation, seeing how other surgeons handled that exact same part or process of the operation, and then conceptualizing what I'm going to do better the next time around. That cycle, having a concrete experience in operation, reflecting on that experience, watching how others do that one event, and then coming up with a new plan, that 4-step process there is actually grounded in learning theory called Kolb's experiential learning process. That's 4-cycle step. And I found that that's what I do. I do that on every single operation. I watch, I figure out, I conceptualize, I study what other people are doing. And I feel like that's exactly what I end up doing on every single operation to iteratively improve my technical outcomes for the very next operation. First part.
Okay.
The second part, Hitendra, as you mentioned, talking about the communication. I think the communication, I'm married. That's a daily lesson of how to communicate, but I have the blessings of leading an amazing team in Orlando and in broader Florida. And I fail daily at communicating well what I think. And so every single day, I'm reflecting on how I can improve the next time and the next time and the next time. And I hope that I fail a little bit less tomorrow and then the day after that. And so that is a constant battle and a constant urge and desire to want to become a better, communicator, but a better leader and a better visionary for the people that I'm able to serve.
Wow. You're very humble and lots of humility in that process of reflection that you just described. The 2-bucket technique, we'll call it, shall we? Dr. Soliman, there you go. So that's great. It's great advice. And as I said, people don't like to ask for this advice. So as surgeons, as we just said right at the beginning, so it's really great what you're saying, actually. It's very helpful to people who are young and old. I think everybody can learn something new and improve what they're doing. So it's great to hear that you're doing that on a regular basis. Now, so I imagine you're in the OR and you've everything looks well that day. The planning's gone well. You know, your communication skills are the best they can be, and you're having a great day. And you're in the middle of an operation. Have you ever come across a surgery where you thought, you know what, they really need to make this tool that's going to help me make my robotic operation even better? Well, if you had that ability to buy something like that, what might it be, or what might you ask for on a wish list?
That's a fantastic question. I mean, yeah.
You know, it's like desert island discs. You know, what do you take on a desert island that you love? So this is a bit like what's going to get you out of a scrape? You know, and I ask all the surgeons this because we're the innovator, aren't we? Because we're using these technologies and we're the early adopters, and you know, so there may not be anything. You may have the perfect setup. I don't know.
Yeah, I think this is a common thing that I think through. Every problem that we have in an operating room requires a solution of some sort. And the reality is nowadays, we're solving problems in the operating room with blunt force, with brute force, whether we're burning it, cutting it, or stapling it. Some form or function, we're beating the tissue into submission. And we're oftentimes relying upon our own 2 eyes and white, or sometimes immunofluorescence imaging light to make a decision. And so truly what I feel like the biggest gap in our knowledge is the next step. I don't think the next step is going to be a better widget or a better stitch or a better needle driver, or a better, instrument. I think actually where we're going to end up making massive strides, like not just an incremental, but a stepwise progression, like a whole generational leap in surgery, is not going to be in the mechanics of surgery. Well, in fact, actually be in the augmented decision making during surgery. What structure is that? Where's that nerve? Should I cut this? Should I go there? I think decision-based analytics and we call it computer vision, you can call it AI, since that's kind of the hot topic. I think that's the next actual advance in the decisions that we're able to make during surgery.
So you were beautifully dovetailed into AI and the future of this technology. So is AI going to take over where we are currently at as surgeons? Is it the future surgeon?
Yeah, no, I think that the day the AI can manage a gunshot wound that'll be Chat GPT would have done something big that day. No, but
Okay.
I do certainly think that there's a place for AI. There's a place for medication. There's a place for chemo. And I think that as we see here in the United States, I'm sure you're seeing it abroad. Take, for example, our rectal cancer numbers. Over the past couple of years, because of TNT and because of just more proper staging protocols and more proper neoadjuvant treatment measures, our rectal cancer operative numbers have plummeted. I mean, right now, I'm probably doing less than 25% volume than I was doing before the pandemic, for example. That's not because we're better doctors. It's just because our decision-making is a little bit better. So using that example, and same thing with biologics and as it pertains to ileopouch surgery, we've almost eliminated the need for pouch surgery. In fact, I just got word that our fellows, they used to require 5 pouches a year. They went down to 3 pouches. And now they're going to go to 2 pouches annually, simply because the volumes are going down, because the biologic efficacy is going up. So I think in a similar fashion, AI will not replace us, but will allow us to be augmented to make better decisions. And I do hope that in 50, 60, or 200 or 500 years, our great-great-great-grandchildren may actually question why we ever cut people open to fix them, as opposed to just give them the whatever treatment that this other, AI sentient being actually was able to come up with.
Yeah, no, I totally agree. More personalized care is certainly changing the way
Yeah.
we do things, right? So if we, I mean, you are a technologist, right, as well as being a surgeon. I mean, you are involved in that area. Do you think that's an age thing? I'm not being ageist, right? But
No. I think that's fair.
You know what I
Yeah.
mean, right? Do you think it's a
I do.
like Gen Z versus
Yeah.
etc. Do you think it's that, or do you just think surgeons who are interested in robotics are interested in technology and these sort of things? What do you think?
Yeah, it's a good question, and I do think that you're gonna have surgeons that use their personal interests and bubble them up during surgery, whether that's a very analog type surgeon or whether it's a digitally minded surgeon. I think you're going to see the crossover, but the strengths of a surgeon outside of the operating room is what she demonstrates in the operating room. And I think that's important. And I know for me personally, I was born in 1980, so I'm very much I'm a zennial, as they say. I'm not a millennial, and I align myself in terms of work ethic with with Gen X. But I
Mark,
guess I'm probably zennial.
I was just going to say that's the lost tribe, that one, 1980.
Exactly. So I'm right smack in the middle. So I find out we joke and argue about this all the time. It's like, I have the work ethic of somebody from I have a pretty intense work ethic, but I'm very digitally minded. And so I think that certainly helps me as I'm thinking through new processes, Lean Six Sigma analysis, and how do you improve operative efficiencies? How do you do certain things both on a technical perspective or an analog perspective? And I do credit a lot of my interests and just who I am. But I do think that surgery calls those people that are very technically minded, and both from a physical perspective, but also a technological perspective as well.
Yeah. Wow. That's your superpower, right? Born in 1980. I'm going to remember that.
Right.
You need to change your name, Mark 1980,
And Mark 80, yeah, exactly.
There we go. Well, yeah, I'm because I look at the residents now, and they manage everything that's app related. We talked about apps at the beginning, and they just have a natural affinity. But the technology, the robot, I mean, I helped build one of the robots that's out in the market now. And one of the things that we did, the older surgeon helped develop, the younger people seem to be just going, well, that's not going to work very well. We need to be doing it in a slightly different way. And it's incredible where they are at the minute. Even my 18-year-old kid showing me how to, do something on an app. I can show him how to change a tire on my car, and he can show me how to fix an app. There we go. So anyway, I digress. So let's just move on, if you don't mind. We've talked a lot about surgery, a lot about robotics, a lot about technology, and about your journey. But one thing that we haven't talked about, Mark, is when you're not working with that superb work ethic, how do you look after yourself? And how do you, I'm not going to say relax, how do you look after yourself?
Yeah, good question. I'm working on that daily.
Yeah.
So, yeah, I have to have a lot of intentionality and I have to have structure in my life. And my worst days are the days that I don't have stuff scheduled. So for me, every morning I'm up 4:30 a.m. I built a gym in my garage, so I'm in the gym by 5 a.m. I'm showering by 6 and kind of moving on with my day. So I take care of myself by physically. I'm in the gym 6 days a week, basically.
Yeah.
As it pertains to just other things in life, I mean, I'm an incredibly lucky man to be married to my wife and have two beautiful children that kill me every single day. But they're great. So I mean, they keep me grounded in everything that I do. But in terms of relaxation, I mean, the less is better for me in terms of what I do, because I do so much at work and so much in terms of my other stuff that I do. So for me, relaxation is something I cherish.
Wow, beautiful. So you're getting your balance in your day by getting up early. That's fantastic. Well, Mark, it's been an absolute pleasure. A real honor to talk to you today. So, ladies and gentlemen, just to finally let you know that we had a wonderful Dr. Mark Soliman, a robotic colorectal surgeon from AdventHealth down in Orlando, Florida. Mark, thank you so much for being on the podcast today.
It's a pleasure. Thank you so much for having me.
Thank you for listening to the Global Robotic Assisted Surgery Podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.